All right, great. Thank you. This meeting is being recorded because it is a public meeting, and the recording will be posted to our committee webpage shortly after the conclusion of the meeting. For everyone's reference, today's agenda can be found under the first tab in the meeting materials. And I just want to take a moment before I turn the meeting over to Judy. I would like to introduce my colleague, Stacy Whiteman. I will be going on maternity leave actually in October or November, depending upon when my future son decides to make his arrival. And Stacy will be taking my place as committee facilitator. So everybody, please give Stacy a warm welcome. She will be helping to run the show at the next meeting, but I'm not going to make her go through that today. I just wanted to introduce her to you all and have you all be familiar with her. So Stacy, if you want to give a wave, that's all you need. Yep, there we go. Perfect. All right, and one other reminder before we get things well underway. We've been making use of the primary care committee email inbox, and I hope to continue to emphasize using that as the primary vehicle for folks sending updates and questions. So I know before it came through our board inbox, but now we're using that primary care committee email. So if anybody has questions about that, just let us know. But that's our main channel. And is everybody seeing the screen okay? It seemed like it stopped sharing on my end. I just want to make sure.
Yes, we can see it.
Okay, so you see the title screen. Great. All right, well then I will turn things over to Chair Zerzenthal to call the meeting to order. Judy, take it away.
Excellent. Hello, everyone. It is 2:05, and I call the September 28th meeting of the Advisory Committee on Primary Care to order. Thank you all for joining us today, and I think we'll have a good discussion. So I'm going to start with an overview of the agenda, which is on your screen. We are going to do with roll call first. After that, we'll vote to approve the meeting summary of the August meeting. At 2:10, we will open the floor for public comment. Next, Kaylee Dufresne will present on the Making Care Primary Initiative and its relation to this committee's work. After that, Shane Mofford from the Center for Evidence-Based Policy will present on and initiate some discussion about primary care data collection and reporting strategies for us to vote on. And I encourage committee members to ask questions and provide feedback. Thank you all for your time and effort. And now I will begin roll call. So I'm going to call on members by first name in the order listed on the agenda, which is alphabetical by last name. So when I call on you, please unmute your microphone, ideally turn on your camera to let us know that you're here, and then go on mute again. So Crystal?
Here.
Sharon Brown?
Here.
Tony? Actually, I know Tony's out today. He texted me. Michelle?
Hi, I'm here.
Tracy?
Here.
David?
I'm here.
DC?
Present. Hi.
Sharon?
I'm here.
Greg? Chandra?
Here.
Meg?
I'm here.
Cheryl? Lon?
Hello, I'm here.
Katina? Mandy?
I'm here.
Jonathan?
Here.
Sarah? Linda? Sean?
Sean's here.
Oh, thanks, Sean. Stacy?
You bet. I'm here.
Ginny?
I am here.
And Maddie?
I am here.
Perfect. Thank you all. I'm going to turn it back over to Jean Marie, who will talk about the August meeting summary.
Thank you very much, Judy. And if everybody could please join me in turning to the meeting summary in the meeting materials. The recording of the last meeting was posted on our web page. Is there any discussion of the meeting summary on the screen or proposed changes? And if not, would someone like to make a motion to accept the summary?
This DC, I move approval or acceptance.
Actually, I have one correction. I was not present at this meeting.
Oh, good point.
And it was Jonathan that called the
Called
meeting
it to order. We will fix that. And it's funny because it says you were absent and then it says you called it to order. So that's an oversight on our part. Oops. We will fix that. Thanks, Judy. Important. Alrighty. And actually for the attendance record, I see Sarah just joined, so I'm going to make her a panelist here. And DC, your motion to approve still stands with the caveat of correcting for Judy.
Yes.
Any second?
Is it important if a C is missing from my name? No big deal, but if we want to add that in the final, it would be good.
Ah, yes. Apologies, Tracy. We'll make sure we do
Oh,
that.
I like Trey. That's good.
That's a typo. Yep. Embarrassing. I'm sorry. We'll fix that. Yep.
I seconded it with a Steve.
Yes. Not Trey. All right. Any other little things to catch or corrections to make? If not, all in favor say aye.
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 Any opposed? Okay, motion approved. And next we will open the floor for public comment. Now is the time for public comment. If you would like to speak when you're called upon, please state your name and affiliation, if any, before you begin speaking. Please don't raise your hand more than once. This helps to ensure that everyone has a chance to speak. You're also welcome to provide comments in writing via email at any time. Please also remember that this is the time for public comments. Any Q&A sessions during the meetings are reserved for committee members to ask questions. Okay. I'm looking for hands. Is there anybody who wishes to make a public comment? We didn't get any in advance in writing, so I'm just looking for any raised hands among the attendees. Okay. Going
And
once.
Keely needs to be promoted to a panelist.
I'm sorry, who?
Keely.
Oh, I thought we already did that.
There she goes.
She is in there. I thought we had promoted her before. Is she in there now?
She's not. She's a panelist. She's here.
She is. Okay, great.
Appreciate the promotion. Thank you.
You're
Yeah.
most welcome.
Woohoo, if only it
Sorry.
came with the pay raise, right?
All right. Well, seeing no hands and hearing no voices indicating desire to speak publicly, I am going to consider public comment closed for the time being. And I will then turn to introduce Kaylee Dufresne, who recently promoted panelist, who is from HCA and is going to be presenting to you all on the Making Primary Care Primary Initiative. Kaylee.
Thanks, Jean Marie. All right, if we could advance to the slide deck here. So thank you so much for having me here today. I'm Kaylee Dufresne. I'm with the Healthcare Authority. I'm in the policy division here. I do a lot of our work thinking about value-based purchasing and how we can do that in a smart way that makes it better for everyone to interact with the healthcare system, patients, providers, all of us. So I think a lot of you are probably already familiar with Making Care Primary. You might have participated in some CMS webinars about this or on Washington's webinars about this. So I encourage you to please jump in with questions, comments as we move along. I'm going to keep this at a pretty high level today, but happy to dive in deeper anywhere that you're interested to hear more. So I'll give that kind of 10,000 foot view of the model. I also want to talk a little bit about kind of multi-payer participation and why we think that's important. We'll talk about eligibility for the Medicare portion of this model, as well as kind of how to distinguish that between the multi-payer aspects of this model. We'll go a little bit deeper into the model, the payment method, and kind of some opportunities on specialty care integration, which we think are interesting. We'll cover the quality performance measures a bit, some updates on the timeline, which is a little more breaking news, and then just some resources that are available to you all. All right, let's do this. Okay, so making care primary at this 10,000 foot overview. Actually, sorry, I want to pause 1 second just to give you all a little bit of context on this. We are not coming to you today asking for, your commitment on any of these things, or that, this is something you're going to be voting on, of course. Really, we want you to be aware of this if you're not already, to know that this is an opportunity for Washington providers and payers to participate in. And just building on the conversation that you had at your last meeting with Oregon, where you heard about, yes, it is important to have that kind of big picture benchmark target for what you're trying to get to, and, in total spending, and to increase investment in primary care. But it also matters the way that you do it. You need to do it in a way that, incentivizes quality, really brings some flexibility to the system, and, encourages that team-based approach. So we think making care primary and our related Washington model can help to support some of that, but we'd love to make you all aware of that and get your feedback on that today. Okay, sorry for that sidestep. All right, so making care primary is a CMMI, the Center for Medicare and Medicaid Innovation, has put out this new primary care demonstration model. This is building on past primary care models that they have. You might have heard of some of these: CPC, CPC Plus, Primary Care First. They're great at naming these. Making Care Primary is the next generation. This is a 10.5-year model, which is a much longer time frame than models that they've had in the past. They are attempting to find cost neutrality in this model. They are not going for cost savings, which is another departure in typical CMMI business. What they're really focused on here is improving quality and sustainability for primary care practices. What we think is great about this model is that it creates kind of this glide path to help providers that haven't dipped their toes into the value-based care space in the past due to, maybe lack of interest, lack of resources, upfront investments to be able to get into this space. So they're really creating this kind of stepwise function for practices to learn and develop as they advance into more advanced payment models and accountability. So the model is really driven from the NASM report a couple of years ago, where they talked about just kind of the dire straits that primary care finds itself in as a result of chronic underinvestments in the system, and how a primary care payment needs to support teams. That team-based care is essential to provide that whole person wraparound, behavioral health integrated care that we know produces the best outcomes for patients. So the Making Care Primary model tries to do those things. It has incentives around health equity, addressing health-related social needs, and sets some expectations for what care teams might look like in these practices. It also, like I said, is trying to advance practices in a stepwise function towards more prospective payment and towards more accountability over time. I will say there is no downside risk in this model, but there is drastically increased opportunities over the course of the model for higher quality bonuses. All right, let's keep going. Thank you. Okay. So this is a slide that I directly stole from CMMI. This is kind of their theory of change here, that one of the struggles for provider practices is there are 1,000 payers, and so there's 2,000 value-based care models, and 20,000, quality measures that you have to report on for all of those value-based care arrangements that you participate in. So what they're really trying to do here is create a model where payers can be directionally aligned with the same kind of key design elements, so that practices can find a bigger return on investment for participating. So if multiple payers can come to the table with, the 10,000 pound gorilla in the room, Medicare leading the charge, that hopefully you can create this kind of tipping point opportunity where it becomes worth it for practices to participate in this and to find some administrative efficiencies in these aligned models. Next slide. So like I said, CMMI is really trying to, we'll give them credit where credit is due. They're really trying to think about how to be flexible enough to bring other payers to the table, but to still prioritize those areas where there could be administrative efficiencies for for providers. So, what they really want alignment on is, the performance measures. They don't want providers to face that 20,000 measure problem. They have defined a, specific set of quality measures that they want all payers to adopt. The exception to that is, for additional populations. A great example is pediatrics. Obviously, Medicare isn't focused on pediatric measures. There's a great opportunity for payers where there are a lot more children in the population to add those measures on. They want alignment and commitment from payers to move towards that more prospective payment, getting away from those fee-for-service widgets. And they want alignment on kind of the methods and type of data that payers will share with providers. Other than those kind of really specific elements, there's going to be some flexibility in how each of the payers implements this model over time. Next slide. Okay, so there's a lot of confusion about how this works. What's HCA's role in making care primary? So I want to just be super transparent about that. Making care primary is a Medicare model. CMMI is testing it in the Medicare fee-for-service population, not Medicare Advantage, not Medicaid, not commercial. They're testing it in Medicare fee-for-service. So all of the design elements that I'm talking about today are the Medicare approach. Like I just said, they want that directional alignment from other payers. They want other payers to come on this journey too. And HCA is very interested to join on that journey. This is really comparable to the primary care transformation model that I think you all have heard about, that we've been working on with a payer, with all the payers in Washington state, with a big group of primary care providers in the state. So we think these are directionally aligned and there's some good synergy there. So what I do want to make clear, we don't yet have the funding or legislative direction to launch this for Medicaid or for our other HCA enrollees, which is the state employees. We are very interested in pursuing that. That said, our contracted carriers, the managed care organizations, and our carriers that work for our PEV and SEB populations could choose to adopt this at any time. They can go directly to CMMI and partner with them on this model and choose to run their business how they want to. So there is kind of that nuance there of, in our fee-for-service Medicaid program, we need to do some work to get legislative direction on this. And obviously, we think that there could be a need for better investment in the primary care system overall, but the carriers can choose whether or not they want to participate in this at any time. All right. So here is the eligibility to participate in the Medicare fee-for-service demonstration, Making Care Primary. So independent primary care practices, group practices, FQHCs, there are a lot of incentives for FQHCs to be involved in this. Indian health programs, certain critical access hospitals. There's a minimum of 125 attributed Medicare fee-for-service beneficiaries required. So who is not eligible to participate? Rural health clinics, concierge practices, grandfathered tribal FQHCs, providers that are already in another CMS or CMMI demonstration are not allowed to participate. So providers that are in the Medicare Shared Savings Program are technically not allowed to participate. There is going to be a little 6-month window where next year where providers can be in both, but then have to make that decision at the end of that 6 months, which direction they're going to go, Medicare Shared Savings Program or Making Care Primary. A little note on the rural health clinics. This is a function of an operational challenge that CMS has in, working through the cost-based reimbursement and how they execute that in their system, and transitioning that into the version of payment in this model was too challenging for them to figure out. So of course, who else is excluded here? Pediatric practices, like I talked about. We are very worried about that, of course. And we are very interested in seeing how we can make sure that this type of structure is available to our pediatric practices, to RHCs in the state, unfortunately outside of the Medicare fee-for-service program, but keeping in line with these same principles and moving in this direction for the rest of the primary care system. All right, next slide. Okay, so CMMI has defined, like I mentioned before, kind of this glide path towards increased accountability over time, and increased kind of capacity building over the course of 3 tracks that they've developed. So in track 1, providers that really haven't participated in any kind of value-based arrangement before, might not have care teams built out quite yet, or need time to build the infrastructure to do all of those things. That's really track 1, building that infrastructure and creating the kind of workflows and referral pathways that are needed to succeed in more advanced payment methods and accountability. Track 2 is really to take the next steps to implement those new workflows and care plans, to build up some collaborative relationships with specialty care providers, some more accountability on quality of care. And then track 3 really goes all in on that. So optimizing the types of payments, really implementing the population-based payments, the population accountabilities, the data sharing. So some really stepwise functions here. CMS has standardized the amount of time that practices would spend in each of these tracks. So track 1, 2.5 years, track 2, 2 or 2.5 years, and track 3 then for the remainder of the time. Practices do have to advance along this spectrum. You can't sit in track 2 in perpetuity. You really do have to keep advancing over the course of this 10.5-year model. Next slide. This is a nice high-level illustration of how the payment model works. So really transitioning away from fee-for-service over time. You'll see in track 1, that continued fee-for-service basis, what we're all familiar with. Track 2, they would start to move to a 50-50 split. So take historic utilization and spend, and split that into some prospective monthly payments, some continued to be in fee-for-service. Track 3, you get to full prospective payments. CMS is going to offer some enhanced investments in this. These are going to be either quarterly or monthly per beneficiary, per quarter payments that will support care coordination, building up specialty care relationships, case management, some of the things that aren't currently reimbursable in the fee-for-service system, but encourage that team-based care. And then, like I mentioned, there is, as you can see from this illustration, some pretty drastic increases in potential bonus payments over the course of the model. And I can speak a little more about that on the next slide. So these are the different type of payments that exist in this model. I think we talked about the prospective primary care payment. That's intended to be all-encompassing of all types of primary care services. The enhanced service payment I mentioned is for some of those, care coordination, non-reimbursable things. The enhanced service payment will be adjusted on based on some clinical indicators and the area deprivation index. So some attempts to really reflect the community risk profile of an attributed population. The performance incentive payments, that bonus payments, it increases from about, I think it's like 3% of total payments in track 1. Track 2, I think it's around 25 to 30% of total payments is the upper max potential. And then track 3, the upper potential is up to 60% of total prospective payment. So some pretty high potential reimbursement there. Obviously, that's met with certain quality expectations, which we'll get to on another slide. There are some upfront infrastructure payments available to providers in this model. It is certain qualifying providers, so based on size, rurality, participation in VBC models in the past, but there will be some funding for some providers that might need that upfront payments, and it's no risk. It won't have to be repaid to CMS, I think, unless a provider drops out of the model early, but other than that, the money wouldn't have to be repaid to CMS. And last but not least is kind of this innovative approach on specialty care integration, which I think is on the next slide. Why don't we go to that? So CMS is trying to think about how to engage the specialty care system in this. This is one of their big learnings that they took away from some of their other primary care demonstration models, that there really has to be that support from specialty care providers and those relationships between specialists and primary care practitioners to really create better coordination and experience for patients. So under this model, there will be 2 new codes available to participants. For primary care practitioners, there will be this e-consult code. So they can build this for the time that they spend coordinating with specialty care providers and working with them on, patient care needs, documentation, et cetera. And then for specialty care providers that have these kind of formalized relationships with PCPs under this arrangement, they will be able to build these ambulatory co-management codes, again, for that time that the specialists spend with the primary care practitioners in that coordination and advising the PCPs on management of a treatment path. Next slide. All right, long promised. Here are the performance measures that CMS has selected for this program. A lot of measures that we're all super familiar with on chronic conditions, colorectal cancer screening, 2 measures on screening and depression, screening for depression and depression remission. There is new NCQA measure on screening for social drivers of health. And actually, I think that CMS has decided not to use that NCQA measure, but to use CMS's version of the screenings for social drivers of health. They're similar. I think it's a little bit of a broader, the types of screening tools that can be used are a little more Medicare patient oriented. There's also this patient-centered primary care measure rather than using the, a CAP survey. CMS is thinking about this primary care survey measure of satisfaction. There are some cost and utilization metrics included in this. So for non-FQHCs, there's total per capita cost and emergency department utilization. For everybody, there's total per capita cost and emergency department utilization. For non-FQHCs, there will be a total per capita cost improvement expectations. And for community health centers and Indian health providers, there is an emergency department utilization improvement measure. Next slide. All right, here is the timeline that we're looking at. So CMS has released their request for applications from providers. It's linked in your materials book. That application is due, I believe it's at the end of November. So they're really encouraging providers to get started on that application, even if they're not certain, providers are not certain that they want to participate or don't have time to finish the application. If providers get that started, they can expect kind of a tailored outreach from CMS to help support them through it, help make decisions, and it'll give CMS some good feedback if providers are actually interested in this thing. One update to this slide, this actually came out from CMS at the end of last week when it was too late to make an update in the slide deck. CMS was planning to solicit payer alignment in October. They have revised that timeline. They will request payer interest applications in February of 2024. So then roughly about the same time in like March is when both payers and providers will be made public of who's participating. Participation agreements will go out from CMS, and then there will be, further implementation steps between March and when the model launches in either July or August of 2024. And my final slide here is just resources. The CMS Making Care Primary website is here. I will say there was a really excellent webinar hosted by AAFP, co-hosted by AAFP, ACP, and the AMA yesterday, where CMMI folks attended. The questions from the practitioners on the call were really great and thoughtful. So I highly encourage you all to check that out if you're interested in hearing more, especially from the practitioner perspective. And the AAFP has put out some really great resources to help practices make decisions. There's some, what track should I fall into? They are also working on creating some kind of plug and play financial modeling for practices to help support that decision. So many things coming out every day about this model. And I want to pause before I take any questions. Judy, anything you'd like to add about Making Care Primary?
Yes, thanks. I am really excited about this model. I think one thing I want to add about how we're talking about how Making Care Primary and the primary care transformation that's been being worked on sort of fit together is we view them as two roads that are merging. And so I think that that'll especially be where pediatricians fall in, is that these will sort of merge together into one thing that is called Making Care Primary, because commercial payers will sign on, and we'll see if Medicaid signs on, but that's sort of the plan. So just to emphasize that piece.
Thank you, Judy. Any questions or comments? Go ahead, Crystal.
I just wonder, you know, we've been talking a lot about cost and how to measure it in claims data. Is that, and I noticed there's measures that we're going to be held to around the cost, which I think is great. Is that fairly aligned with what we're looking at as far as those claim costs that are being used to measure primary care overall spend?
Oh, good.
Scores.
Yeah, good question. So the measures that CMS has selected, could we roll back up to the quality performance measure slide? So they're using a total per capita cost. So that would cross, you know, the entirety of the healthcare system. They're looking at hospital care, acute care, emergency care, everything in there. Whereas some of the work that you all have been doing to define primary care and what you're going to talk about in the latter half of today's meeting, that is more specific on measuring like the total primary care cost. So CMS hasn't weighed in the same way on, you know, a definition of what claims count as primary care. That's kind of outside the scope of their measurement in Making Care Primary.
Right. Can I ask a follow? Yeah.
Yeah.
Understood. So then our primary care costs, the claims, the way we're looking at the claims cost is going to be a component of that though.
Yeah.
Right. The same source. Yeah.
Thank
you.
You got it. Yeah, for sure. I mean, I guess you could say the services that are going to comprise the prospective payment under Making Care Primary, I guess is technically like CMS's definition of primary care services. They are thinking very carefully about what services should be excluded from that. Immunizations are a good example that, you know, we want to keep in the fee-for-service system to incentivize more immunizations always. But, you know, mostly the scope of spending and utilization that happens in these primary care settings would be included in their prospective payment. Go ahead, David.
Yeah, thanks, Kaylee. That was a great overview. I'm curious, have you been in any discussions where you've been able to see what criteria CMS will apply for deciding whether a practice is eligible for track 1 or not? Yeah,
great question. The RFA is immensely detailed if you are struggling to fall asleep at night. I highly recommend picking it up. The main criteria that they have emphasized to us is if a practice has experience on the Medicare fee-for-service side of any kind of value-based payment arrangement. So if they have some experience with a VBP model, then track 1 would not be right for them. If they don't, then, you know, track 1 is going to be more of a viable option. Otherwise, they're, you know, they haven't been, and Judy, I want to look at you too here, that, you know, they're really letting practices self-identify what is the right path for them. And there is no cap on enrollment for the program. There's, you know, there's not a budget limit on how many providers can participate. They're really welcoming. If you think you're eligible in this track, that's where you belong.
Okay, and can you just say your first sentence again? Is it any VBP experience in any line of business?
Medicare fee-for-service line of business only.
Oh, okay. All right. And then, I'm sorry, I have another question. Is anybody else's hand up? Okay. Do you know, for practices that don't get paid straight off the Medicare fee schedule, so for example, an FQHC, is CMS saying whatever payment mechanism you get paid on today, these bonus payments and so forth would accelerate on top of that?
Correct. Yes. Yeah, I don't have it in this slide, but CMS did have a webinar specific for FQHCs and Indian health providers where they gave actually a couple of examples of, a payment calculation that broke it down really nicely. I'd be happy, Jean Marie, if I could send that out to you and you could send that around to everyone here. It's really informative and I think would pithy enough that you'll be able to catch on.
Okay, thank you.
Yeah.
That looks like everybody, but thanks, Kaylee, for coming. And if there are other questions, I'm sure you or myself, you can email us and we'll get back to you as best we can.
Thanks all.
So next, I think, is Shane.
Thanks very much. We're actually going to do a little bit of voting, so I'm going to go ahead and share my screen and use this deck here, if that's okay.
Actually, Shane, can I do the deck for just the first few slides and then give it to you when we vote? There was a change we had to make, and I don't know if we updated it. It's just on one of the slides. So I'll hand it over as soon as we're to the voting. I promise.
Okay, sounds good.
Yep. Okay.
All right. Well, thanks everyone. Let me fix my camera here. There we go. So we're going to start off by just providing a bit of an update on where we're at and where we're going. In front of you, you've seen this slide before. It is outlining the major charges for the committee. We've talked about them previously in 3 buckets. So primary care definition, the data related policies, and policies to increase and sustain primary care. If you could go to the next slide, please. So focusing really on the definition development, you all have done a great job in really marching through what is quite a bear of a task, and we're getting really close to being able to wrap that up. So you've already made it through the development of an initial primary care provider list, so the types of providers specifically that would be included in the definition, the list of settings, and also the list of services. You've done a really good job also of learning about and providing some feedback on core principles related to the current data collection structures and how those could intersect with the definition development. And then lastly, or it was actually, I got those last 2 together, the focus on the principles for supporting the data collection. And we're going to talk about that one more specifically today, because that is an area where HCA has taken your feedback, and we're bringing back a proposal for you to review and then vote on later.
And Shane, sorry, I'm sorry to cut in. For some reason, I thought we had corrected this on this slide, but we had changed 2 of these to say that we're actually still in progress on reviewing other states, because we haven't really completed that yet. We still have to hear from Rhode Island and a few others. And obviously,
that's the next slide. That's the next slide when we talk about policy. This is over.
I'm sorry for cutting. I'm sorry.
No worries. So on the definition piece, in terms of to-dos, we have the data analysis that is long been promised. I know as we are working through the code selection process, there was definitely a strong feeling from the committee that it'd be helpful to see the prevalence of codes or the prevalence of code usage by primary care providers versus by other providers. HCA has done some great analysis. We're in the process of reviewing that, and we're actually going to tee that up to help you finalize the definition in the next meeting, which will be great. We also talked about this in the last meeting, but because ultimately you're making a recommendation on an expenditure target policy, you're going to have to select either a broad or narrow definition, which would be the standard for that official measurement. So that'll be one additional piece that we'll need to work through together. And we have been slowly fleshing out the context around that to help inform that decision, but we'll be tackling that relatively quickly here. And then lastly, it would be to vote on the high-level data collection strategy, which is what we're actually going to do today. So you can see we're really starting to wrap up this aspect of the committee charge, which is excellent. So great job on getting through all of this. If you go to the next slide, please.
Sorry for jumping ahead, Shane. There you go.
Not a problem at all. You're just very excited about policy development, which I can understand. So policy development, the other major charge. So the things that we've gone through together, we developed a general framework for understanding the policy levers to achieve the 12% target. Really kind of understanding that there are a lot of different policies that influence achieving the 12% target because it's a dynamic environment in which the expenditures and utilization occur. We also identify some initial policies of interest within the framework, and we've reviewed 3 primary policy levers based off of how other states have implemented the policy for incentivizing achieving those targets. Still in progress, we are reviewing other state policies and experiences. We've heard some background research that was provided earlier in the process about what multiple states have done. We've heard in person from Oregon, which was a really excellent conversation. We have Rhode Island coming up shortly, as Jean Marie noted. And then we'll be having some additional documentation and research to really help make sure that you have a very solid basis for your final recommendation. It's a big policy and it needs to be right, and we want to tee you up for success. Additionally, the reimbursement models from the charge, you have to develop recommendations for the reimbursement strategies that support sustainability under the 12%. And you just heard about part of that. And I think some of the key anecdotes that, or some of the key messages from CMMI that Kaylee shared really resonate with a lot of the feedback that you've provided. So it's good to see how everything's really moving in the same direction. So to do, continue to gather learnings from other states that have successfully implemented or are in the process of implementing these policies. Develop a recommendation for the specific primary policy. So the primary policy, we've teed that up in prior meetings as being the 12%. So that would be something akin to, expecting 1% annual progress towards 12% for all of the payers. And in that, it would be the timelines for expected progress, be it an annual standard or some other mechanism. And then the specific mechanisms to incentivize achievement as you're charged to make a recommendation on. Additionally, one of the great things about learning from other states, one of the things that was really informative, particularly from the last meeting in Oregon, is what ancillary policies or secondary policies they're recommending that are really key to the success of being able to hit the targets in their states. We've heard value-based purchasing, that connection, that really ties in tightly with your need to provide some insight on that through your policy as well. We've also seen through the research side of things, and I think we'll hear about it from Rhode Island more, about some of the other policies related to cost controls. So I think in a nutshell, what I would say here is that you have quite a suite in front of you in terms of charges, but you've done a lot of work to really build a solid foundation for the recommendation. We have a few more steps to go, but we're really starting to close it, which is great. So, if you could go to the next slide, please. So as I foreshadowed pretty heavily earlier, we're going to be talking next about the data collection strategy. The specific one that we're talking about today actually spans multiple areas within the charges. If you could go to the next slide, please. You may remember this slide from prior presentations. We essentially talked about how the data collection from payers works today. And there's really 2 key mechanisms: the all payer claims database, which is claims level detailed data submitted by a subset of payers. Excuse me. This is data that can be queried by HCA for calculation. It does not include ERISA plans, and it does not include non-claims based expenditures. And then there's another process. So the HCA aggregate data call It's aggregated data submitted by all payers. It does include some ERISA plans data. It includes non-claims-based expenditures. And HCA has the flexibility to update the reporting specifications, which is a very useful flexibility. If you could go to the next slide, please. So when we talked about what should be the strategy for collecting data for measuring progress towards the 12% expenditure targets, we talked about some of the pros and cons between the different methodologies. This is a highlight of some of the key considerations. So with the APCD, you have a different set of challenges than you do with the aggregate data call. Under the aggregate data call, you have multiple entities that are calculating primary care expenditures based off of state-provided specifications. Kind of the key challenge with that process is that it leads to the opportunity for inconsistent application of the specifications, which could reduce potentially the accuracy, but also the transparency, as noted in this next bullet, from that reporting process. Additionally, it can be considered an administratively burdensome process in that it's partially duplicative with existing APCD reporting guidelines. So, no perfect solutions here. However, as you may recall, you all voted on some principles and had some good discussion about these different strategies. HCA has taken that and brought back a proposal for the strategy going forward. If you could go to the next slide, please. And that proposal attempts to get at the best of both worlds. So it's a hybrid solution. So the proposal is that for the claims-based expenditure components of the data calculation, that HCA would retrieve the data from the APCD and calculate that data. That has the key benefit of standardizing the reporting and the interpretation of the data. So getting back to one of the challenges that we just talked about, which ultimately could increase the process transparency. And it's also leveraging existing framework in the state for the data collection of the claims level detail. The non-claims based expenditures, those would actually still need to go through the aggregate data call process. Simply because that type of data doesn't currently exist in the APCD, and so you need to have a solution for it. It's still leveraging the flexibility of the customizable specifications, which will be useful for ensuring that whatever value-based purchasing requirements or connectivity to value-based purchasing and the 12% expenditure targets can be accurately captured and reported. So like I said, there's no perfect solution. There's definitely challenges with the different strategies. We've had some good discussions. You all provided some key principles, and based off of those, HCA has this hybrid solution in front of you. The next step here is actually to vote on whether or not you support the hybrid solution. And I'm going to kick it back to Dr. Zerzenthul to lead any discussion and lead us into the vote. And then while that's happening, Jean Marie, do you want to allow me to present? And
Yes.
I will.
Yeah, you go ahead and take the wheel. That is totally
Okay.
fine. Thanks for your
Perfect.
patience.
Thank you very much.
Once Shane gets that up, then Judy, you can call for a motion. And David, it looks like you have a question in the interim.
Yeah, Shane, the thing you're calling the aggregate data call, is that the request that comes out from the Transparency Board?
Yes.
Okay. And then just out of curiosity, the analysis that's being done to implement the definitions, is that being done on APCD?
It is, yes.
Okay, thanks.
Yeah, absolutely. And Jean Marie, apologies, but I'm getting an error message saying that the host needs to allow me to share.
Okay. Tamara, are you able to transfer to make Shane a co-host? I thought he already was, but
Yep, I'll do that right now.
thank you so much. Thanks, everybody, bearing with the technical transitions.
And if you prefer, we can do a standard voting process and do it either with thumbs up or however Judy would like to.
While we're waiting, does anybody have motion if there isn't further discussion?
And for clarification, the motion is to approve the hybrid collection solution. That's what we're asking for here.
This is
This-
Michelle. I move to approve the suggestion.
Did I second that, this DC?
Perfect. So as Shane gets this up, we are again using the poll everywhere. And please join, please put your name in so that we know that you voted for the minutes, and then vote away.
Can you tell us again how to get to poll everywhere, please?
Yeah, so there's, oh, go ahead, Judy.
Go ahead.
So there's the little, it may be a little bit hard to read given size, I apologize, but at the top, there's the pollev.com. So you can see that CEBP. So you go to that web page and then you can vote from there, or you can join by text if that's easier. So you can send a text and I can, let's see if I can't add it in the chat. I always want to do that, but we don't have that. So if you want to send by text, it's CEBP OHSU 925. That's who you're sending it to. Otherwise, you could do it to
the text to
22333.
So is that little square what we're supposed to do for the website, or just copy and paste?
either one. You can't copy and paste it because it doesn't work, but you can either text or
It's a
go to
little
the
bigger.
website.
It's too small to capture.
Yeah, I
Yeah,
wouldn't
Shane,
go
can
with this
you
one.
take it out of this view because we can see what the next slide is, and so it makes it kind of small.
Yeah, thanks very much.
And Shane, are you able to see
My
the number?
aging eyes. Oh, but now we can't see the top part. Duh.
Marie, you could email the link.
Oh, there it is.
Yes. Let me,
That works.
give me a second. It's just slow. For some reason.
Can I ask a question?
Sure.
Just a little bit of feedback. I may have missed it at the beginning of this presentation. I voted to agree, but if we'd started with that we were voting on this, I thought we were more just consuming the information. I didn't know I was making a decision. I think I just would have engaged with it differently. You know what I mean?
Sure.
So whenever we vote, if we could know in the beginning of the presentation, that'd be great.
We'll give it a minute more.
Well, give just a sec, Shane. Sorry, I'm trying to make sure. It took me a second to get everybody's emails pulled up, so I want to make sure. Can you see the numbers of people who voted? Because we want to make sure we have a quorum. Are you able to see how many people for each?
Not while I'm
It's just a
presenting.
percentage.
Okay, well, I just sent the link. Did folks get that via email?
Jean Marie, I see that Sean West is also raising his hand. I know he hasn't accepted the invitation to be a panelist. We've sent it a couple times. I assume that that's a vote yes, but we may just want to check in on.
Thanks. Yeah. And I did include Sean, I believe, in the email that I just sent the link out to. So if he got that, he should be able to vote that way. In fact, yes, he was included on that.
We
But
just got that email if you're looking for somebody to confirm that it was received.
Yes, please. I was hoping for that.
Sure.
Thanks, Jenny. Yeah, so Shane, if we can just give it a little more time. Thanks for bearing with me, everybody. Maddie, you have a question?
Yeah, I just texted it because I tried going to the web and it's not going anywhere. It's just looking at me like I'm crazy. Unless, do you have to put web in there, or you just start it with the www.poll.ev?
That's a good question. Is that an error, Shane? Should it be web poll EV or is it just poll EV?
It's just the blue portion.
Okay.
Yeah, and that's what I did, and it's doesn't want to go anywhere. I did text, but I'll keep trying for future.
Sorry about that, Maddie.
If you text it, it'll show up here. So no worries. Thank you for letting us know.
Yep. If for some reason there are any other glitches, we can also, oh, I do see Sean here. Looks like you joined. Sean, are you able to speak? I tried to unmute you. Tamara, is there any way you could assist with that?
Hello. Hi, Jean Marie. What is it that you need?
I saw that Sean had his hand up. I thought he had joined as a panelist, but maybe not. So,
okay.
We have 14 responses as well. And
okay.
Back on. I was able to vote yes. Thank you.
Okay, but you can now.
Yep, I did vote. Thanks.
Okay, great. And sorry, Shane, you said 14 total have voted, or?
That's correct.
Okay. And I believe there were 16 when I counted, so that's only missing 2 folks, and that should be a quorum because I know we've lost 3 people from our original group. So that's over half of folks who voted. So do we want to call it? Judy?
Yes.
Yes.
Okay.
Thank you. We will close this after a long and painful voting process. Sorry, we're out of practice. Maybe we need to vote every time so that
we did end up getting all 16 at the end. So thanks for that. So that passes. Thank you very much. Just 2 more things here. Let me reshare, but really brief actually. So maybe not. As I said before, so when I was teeing up the work to be done, I said we'd be voting on this today, and we just did. I also said that we need to vote next time on the measure definition set, which would be informed on the data analysis. So that's really the next step, and I just wanted to prepare you for that as well. And then the last thing that I would raise is that we have the Making Care primary reminder. You have that in the deck. There's links to the application. And just once again, as noted for that program, there's potentially a lot of opportunity for practices that are interested in participating, but there is a one-time onboarding opportunity to that program. So if you can please share that with your peers and help get the word out, it's ultimately in the best interest of the delivery system of Washington. So I appreciate you sharing that information as well. So, and that's actually all I have. So turn it back to Jean Marie.
Thanks, Shane. And that's actually it for today. I anticipated today might be a short meeting, so you all get some time back. Judy, do you want to officially close?
Yes, I will do that. So thank you all for participating in today's discussion and voting. While it seemed short, that vote is actually really critical for us to keep this moving forward. So thank you. The recording and summary of this meeting will be posted shortly on our website, and our next committee meeting is for certain going to be jam-packed. It is on October 26th at 2 p.m. and I look forward to seeing you all then. Thanks so much.
Right. Thanks, everybody. Take care.